PD-L1 testing has been investigated intensely in kidney cancer as it has been in other diseases, and this actually goes beyond the application of checkpoint inhibitor therapy. There's data from the COMPARES trial, which was a tyrosine kinase inhibitor study that compared sunitinib to pazopanib using PD-L1 immunohistochemistry and demonstrating that patients that are treated with tyrosine kinase inhibitor and have higher tumor expression of PD-L1 levels have adverse outcomes, meaning patients do worse with high PD-L1 levels. So it's suggesting that this aspect of tumor biology may in fact add to the aggressiveness of cancer. Now several years later, we have data from the IO trials that have helped us to understand that it not only is an adverse prognostic marker in terms of the biology of disease, but it is a predictive marker that shows favorable outcome in immunotherapy-treated patients, which makes sense because it's the target. The early studies for PD-1 and PD-L1 inhibitors in this disease suggested that response rates were higher in patients that were PD-L1 expressing on tumor cells and or immune cells. It's important to know, and has always been stressed, that lack of PD-L1 expression does not preclude patients from having benefit from these agents, so it should not lead to these patients not being considered from these trials. The randomized phase 3 trial that led to the approval of nivolumab in the second-line setting, the CheckMate 025 study, compared nivolumab to everolimus in TKI pretreated patients. And importantly, PD-L1 expression status did not seem to affect the superiority over everolimus in these patients, meaning whether or not a patient was PD-L1 positive, they did better with immunotherapy than with the mTOR inhibitor. So at the time, PD-L1 testing was deemed not a relevant marker to make treatment decisions. Since then, we now have the CheckMate 214 study, which again is the ipilimumab, nivolumab versus sunitinib trial that compared tyrosine kinase inhibitor therapy to combination IO therapy. And of course, PD-L1 expression status was investigated on that trial. Again, with the DACO assay, we tested for expression on tumor cells, not on immune cells. And the best way to summarize the data is that we again saw an adverse signal for the TKI-treated patients, meaning the cancer-specific survival with sunitinib therapy was worse in PD-L1 expressing tumors. And on the flip side, patients that were treated with the immunotherapy combination were more likely to benefit from immunotherapy if they were high expressors. So, for example, the CR rate in intermediate poor risk patients was 9% across the board, but if we looked at patients who were PD-L1 positive and had intermediate poor risk disease, the CR rate went up to 16%. If we looked at overall survival benefit of ipilimumab, nivolumab over sunitinib in PD-L1 negative versus PD-L1 positive patients, then we note, and Bob Motzer has presented this at SITC in 2017, that superiority was seen in both instances, but it was much more marked in patients that were PD-L1 positive. So the hazard ratio went down to below 0.5 in patients that were PD-L1 high expressors, comparing the IO combination over sunitinib. So in my mind, it again is not a marker that will help us make decisions between two regimens, but it's certainly prognostic in terms of the tumor biology if we do not consider therapy. I think it is predictive for a combination immunotherapy with ipilimumab, nivolumab. And knowing that a patient is PD-L1 positive up front, should be a strong motivator to pursue ipilimumab, nivolumab combination therapy. That being said, as stressed before, a PD-L1 negative patient can still benefit and is still, according to the CheckMate 214 data, more likely to benefit from that combination than from sunitinib alone.